Hello students, can you hear my voice? Hello? Hello students, can you hear my voice? Reply, only 59 of you have been or online. Should I wait? Good morning. Should I wait or you want me to start? Now can you see me now? Yes, is my voice absolutely clear or not? Okay. Shall I start? Yes. Yeah, today's class is డోర్ కొంచెం తీసే ఉంచాను. Hello. Fine, then I'm starting the class. The topic for today is juvenile nasal angiofibroma. So what does this name point towards? When you say juvenile, what do you mean by juvenile? Juvenile is an age group from 10 to up to 16 years age group. This age group is known as juvenile. Okay, and the second word in this topic is nasopharyngeal. This nasopharyngeal points towards the location of the tumor. And the third part is angiofibroma. Angio means vascular, fibroma means fibro means connective, oma means tumor. So it's a fibrovascular tumor located in the nasopharynx, seen in the juvenile age group. Okay, so am I clear? Only 75 of you are there. Should I wait for them? Or continue? Okay. Now coming to the introduction. Juvenile nasal angiofibroma is a uncommon, benign, very important, it's a benign tumor and extremely vascular tumor. Now coming to the brief history. The juvenile nasal angiofibroma has been documented since the time of the Hippocrates, that is 4th century BC. In some of his books, Hippocrates also described this angiofibroma as a hard polyp in the nose which weeps blood. Okay, so the main symptomatology of this tumor is epistaxis, that is bleeding from the nose. That's what he has observed. Next, Shaheen in 1930 has reported that reported the first case in a female patient. So this is also significant. I'll tell you why. Then next, Friedberg used this term angiofibroma in 1940. Honduza recorded the youngest JNA patient. His age was 8 years. Figge and Davis emphasized the role of surgery and management in the juvenile nasal angiofibroma or JNA. Now coming to the epidemiology. The frequency. It amounts to less than 0.5% of the all head and neck tumors. In some books it has given as 0.05. That is wrong. It is 0.5%. Okay. And the frequency is ranges from 1 in 5,000 cases to 1 in 60,000 cases in routine ENT patients. Okay. That come to OPD. If you screen them, you may find one case in among 5,000 to 60,000 patients. Now coming to sex. It says that here, as far as UG is concerned, you remember that it is exclusively in females. But obviously that is not correct. It is most common in males. But there are cases where this angiofibroma is reported in females also. Okay, but as far as examination is concerned, you remember that it exclusively is present in males. The onset is present in the second decade. Whenever you say second decade, it means from 11 years to 20 years. So the range being 7 to 19. This is the age group. Commonly you will find JNA. It is rare in patients older than 25. Because if the patient already has it, he invariably presents before the age of 25 years. Now coming to basic anatomy, we already dealt with this. Just to brush up your anatomy, we'll deal again with this. This nasopharynx is considered as an anatomical blind spot because it is not visible directly. The size is 4 by 3 by 2 centimeters. It is present below the base of the skull. This is the base of the skull or middle cranial fossa. Middle cranial fossa. It is present directly below the middle cranial fossa. Now coming to the boundaries. See, this is the nasopharynx. It is bounded anteriorly or it is related anteriorly to the choanal orifice, that is the posterior nares and also posterior margin of the septum. Floor. Floor is free. See, this is all floor. This is the anterior part of the floor and this is the posterior part of the floor. Anterior part of the floor is related to the soft palate. Posterior part of the floor is free. This is free. This is free. It communicates with the oropharynx. Now coming to the roof. This is the roof of the nasopharynx. This roof is continuous with the posterior wall. So whenever you talk about the roof of the nasopharynx, we will also talk about the posterior wall because it is a continuous structure lined by mucosa. So it is related closely to the sphenoid. This is the body of the sphenoid. This is the sella turcica. This is the clivus. Okay. And also this roof is related to the body of the sphenoid. Posterior wall is related to first and second vertebrae. Okay. So coming to the lateral wall. Lateral wall contains eustachian tube surrounded by an elevation known as torus tuberous, and little posterior to that they will find fossa of Rosen-Muller. Okay, in the upper part, that is at the junction of the roof and the posterior wall, you will find the adenoids. Are you able to understand? Please reply. Are you listening? Okay. Now coming to another important uh, 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 structure, you need to know the anatomy of this before, because it is vital to understand the extension and spread of the tumor. Next slide heading is pterygopalatine fossa. Fossa is nothing but an enclosed space. It is an inverted teardrop of pyramidal space. The content of the space is maxillary nerve, maxillary artery, and pterygopalatine ganglia. Now coming to the anatomy of the pterygopalatine fossa, brief anatomy. So this is the space. Okay, it looks like a inverted teardrop or pyramidal structure. Anteriorly, it is bound by the posterior wall of the maxilla. Okay, posteriorly by the pterygoid plates of the sphenoid bone. See, this yellow thing is entire sphenoid bone. Superiorly by the inferior surface of the sphenoid bone and also orbital plate of the palatine bone. Okay. Medially, switch off your microphone. Someone has switched it on. I'm getting the disturbance. Mute yourself. Okay. And medially, it is related. This is the medial wall. Medially, it is related to palatine bone. Okay. In the medial wall, you can see a spinopalatine foramen. This palatine bone contains three processes. One is attachment to the inferior turbinate. Other one is the palatine orbital process. This is the orbital process. This is the palatine process or pterygoid process. The pterygoid process attaches to the pterygoid plate. Orbital process forms a part of the orbit. In between these two processes, you have a notch. This notch is known as spinopalatine notch. This notch is superiorly completed by body of the sphenoid, forming a enclosed structure known as a foramen. This foramen is known as spinopalatine foramen. It gives out spinopalatine artery and also nasopalatine nerves. Okay, also nerves from the pterygopalatine ganglia. So did you understand the anatomy of the spinopalatine foramen? I think it should have been covered in the nose as well. I think it is covered. Okay. So laterally, this pterygopalatine fossa through the pterygomaxillary fissure communicates with another space known as infratemporal fossa. Inferiorly, it is free between the anterior and posterior walls. There is a space. It communicates inferiorly free, and it gives out a canal known as greater palatine canal or foramen, giving out greater palatine nerves and vessels. Okay, this is brief anatomy about pterygopalatine fossa. Now coming to etiopathogenesis. So there are several theories of how this tumor forms and why it forms. These are few important theories. There are many. These are few important theories, and it is a 4 marks question for you. So now come to Ringett's theory. What did he say? In 1938, Ringett's believed that JNA always arises from the periosteum of the skull base. Periosteum of the skull base. He felt that the tumor arises from the periosteum of the skull base. Now coming to second, Martin et al. When you say et al., Martin along with his team, it means that in 1948 proposed what is known as a hormonal theory, suggesting that this tumor resulted from the deficiency of androgens or overactivity of the estrogens. This hormonal stimulation is responsible for angiomatous components seen in JNA. This is what he felt. This is what he proposed. Then came Sternberg. In 1954, he proposed JNA could be a type of hemangioma. Hemangioma is also a benign tumor caused by the abnormality in the vasculature where there will be pooling of the blood. Similar to cutaneous hemangioma seen in children, and is proposed that it regresses with age. Next one is Osborne. In 1959, he considered two alternatives to explain the etiology of the JNA. He proposed that this JNA could either be a hamartoma or a residual fetal erectile tissue which was subjected to hormonal influences. When you say hamartoma is nothing but a well-differentiated tumor consisting of different structures, mixed structures which are not common to that area. That is what hamartoma means. Okay. Now coming to the next theory. Girgis and Fahmy, they observe cellness of undifferentiated epithelioid cells, also known as gelbelen. Gelbelen means undifferentiated epithelial cells at the growing edge of this angiofibroma. This appearance was somewhat similar to paraganglioma, so they concluded that JNA could be a paraganglioma, but still it is not proved. So it is called a theory. That's why it's called a theory. The most commonly accepted theory is JNA originates from sex steroid stimulated, that is testosterone stimulated hamartomatous tissue located in the turbinate cartilage. This is the most accepted theory, that JNA is dependent on sex hormones and it is nothing but a hamartomatous tissue. This is the common understanding. Now, coming to sex hormone receptors. As this tumor almost exclusively is found in adolescent boys, so you should have a speculation that because it is seen in only boys, that too in adolescent boys, it should be somewhat related to hormones. So that was the initial speculation and perception based on which further research went on. Recent immunocytochemical techniques have shown that androgen receptors are present in at least 75% of the tumors. When these tumors, after excision sent to pathology, they have done some immunocytochemistry. They have found that in 75% of the cases, there were androgen hormone receptors. These receptors are found in both vascular and stromal elements. And they also found a small proportion of tumors having progesterone receptors. But there were no estrogen receptors. In spite of heavy research, they did not find any estrogen receptors. Okay. Now, second thing which they thought could cause this tumor or help in the growth of this tumor, that is angiogenic growth factors, that is VEGF or vascular endothelial growth factor, that has been found. They have found and isolated this growth factor on both endothelial and stromal cells, perhaps indicating both cells play an important role in the tumor development. The third one is the insulin-like growth factors. They also found that overexpression of insulin-like growth factor 2 has been found in large number of cases. The gene for this insulin-like growth factor or IGF2 is found on the 11p, that is short arm of the chromosome 11. They also found overexpression of this IGF2 might be associated with increased tendency and recurrence and also poor prognosis of the patient. So in patients in whom they have found there is overexpression of IGF2, they have invariably a poorer prognosis. That's what they found. Now coming to familial adenomatous polyposis. This is a genetic disorder. Please mute yourself. Someone has switched on the mic. Okay. The JNA, this familial adenomatous polyposis is a genetic disorder caused due to the mutations in the adenomatous polyposis coli gene, that is APC gene, which is present in the chromosome 5q. You might have already known from pathology. So people having mutation in this gene have been found that they have 25 times more tendency to form to get this juvenile nasal angiofibroma than in normal population. This APC gene regulates beta-catenin pathway. This compound or protein is required for cell-to-cell adhesion. So any abnormality in this pathway can influence formation of a tumor. And other factor, that is transformation growth factor beta, it helps to regulate the cell cycle and induce angiogenesis. They have even isolated this also from the tumor. So they, after analyzing everything, they have found that VEGF is expressed in almost every tumor, and this TGF beta is found in most of them, indicating that they play a crucial role in tumor formation and also the aggressiveness of the tumor. Okay. And they also found that estrogen and progesterone receptor expression was low, to indicate that they don't have any relation to this angiogenesis or etiology of this disease. Another theory is juvenile nasal angiofibroma might be related to first branchial arch artery. It has been proposed that the tumor origin is based on an incomplete regression of the first branchial artery. They are proposing that it is a congenital disorder in which there is incomplete regression of the first branchial arch artery. That's what they're proposing. They say during embryological development, the first branchial arch artery finally recedes close to the pterygoid base. That is, it regresses close to the pterygoid base and the spinopalatine foramen regions. So, as they found that it is receding close to these two structures, that is pterygoid base and spinopalatine foramen region, this proposed that it could be the cause for JNA, because the JNA also originates close to these structures. And the third thing is the vascular remnants of this artery are incorporated into spinopalatine and maxillary arteries themselves. That is the third suspicion or reason. So both proximity of the tumor origin and its main blood supply from spinopalatine artery and maxillary artery can explain by this theory. Okay, because the main arteries for spinopalatine and maxillary artery are the main blood supply for JNA, and their vascular remnants of this artery are closely related to these structures. So they are proposing this might be the cause. The fourth thing is the persistent vascular remnants of the first branchial artery are in close contact with the internal carotid artery. So they also found that in some cases there is vascular supply from internal carotid artery also to this JNA tumor, and they propose this might be the reason for that. Okay, this theory also elucidates the common finding of residual tumor at the pterygoid base and clivus. Explain why it is necessary to drill the bone in recurrent cases. I'll talk about this in the later slides, don't worry. Now coming to pathology. Whenever you talk about pathology, you should talk about both macroscopic, that is gross appearance, and also microscopic appearance. So macroscopically, grossly the tumor appears as a rounded, nodular, reddish, non-capsulated, this is important, non-capsulated polypoidal mass that is covered by the normal nasopharyngeal mucosa. So as this structure is non-capsulated, it shows expansile growth pattern and it infiltrates, which accounts for its aggressive behavior. So why this tumor is aggressive? When someone asks, you have to answer that because it is non-capsulated and it has expansile growth, it spreads, it has aggressive local spread. Now coming to microscopic features. The tumor consists of proliferating irregular vascular channels within a fibrous stroma. The vascular component is more in young. As age increases, the collagen content decreases. So what they say is, what they found is, in young tumors, there is, in young patients, the tumor contain more vascular component. As the age increases, the vascular component has been replaced with collagen content. As you know, it has two components, that is vascular component and fibrous or collagen component. The most important feature, why does this tumor bleed? This tumor bleeds because the blood vessels of this inside this tumor typically lack smooth muscles and elastic fibers in the tunica media. So this is the reason for sustained bleeding. Normally, when a vessel is injured, it immediately goes into vasoconstriction to decrease the blood loss. But to go into vasoconstriction, the muscles should be present and they also should work. In this angiofibroma, they found that it lacks the smooth muscle. So when there is no smooth muscle, it cannot constrict. So it causes sustained bleeding. And the characteristic absence of infiltrate, when you say inflammatory infiltrate, means it does not show any lymphocytes or neutrophils or macrophages in this tumor. Helps in further distinguish it from more common nasal polyp. In nasal polyp, normal nasal polyp, in an inflammatory nasal polyp, grossly it may appear like angiofibroma. But once you take the biopsy and suction, it shows inflammatory infiltrates along with normal tissue without any vascular components. In angiofibroma, you will find vascular components. Okay. See, these are the delicate thin-walled blood vessels, and this is hypocellular stroma. These are spindle-shaped cells, characteristic of angiofibroma. Now coming to the pathophysiology. So now coming to origin, where does it originate from? So the spinopalatine foramen and the superior, most precisely the superior margin of the spinopalatine foramen is the site of the origin for juvenile nasal angiofibroma. As I told you before, the spinopalatine foramen is formed by the orbital process and pterygoid process of the palatine bone to form a spinopalatine notch. This is a spinopalatine notch. This spinopalatine notch is enclosed superiorly by the body of the sphenoid. This is the body of the sphenoid forming the foramen known as spinopalatine foramen. Okay. So the characteristic of this tumor is, instead of infiltrating and invading the surrounding tissue, the tumor displaces and distorts, relying on the pressure necrosis, and destroys and pushes through its bony confines. So it identifies the path for least resistance and it grows. Once the least resistant pathways are used up, it pushes the surrounding structures, increases the pressure there, causing pressure necrosis, thereby spreading. Ultimately, it causes necrosis of the bone also. Due to pressure, it doesn't infiltrate into the bone. It causes pressure necrosis. And in 10 to 20% of the cases, they found intracranial extension. Now coming to extension. So from the spinopalatine foramen, from the spinopalatine foramen, if the tumor goes medially, it involves the nasal cavity, nasopharynx, and soft palate. Okay. If from the spinopalatine foramen it goes laterally, if it goes laterally, it enters the pterygomaxillary or pterygopalatine fossa. From the pterygopalatine fossa through the pterygomaxillary fissure, it enters the infratemporal fossa, and ultimately it enters the infraorbital fissure. See, again I'm going to explain. This spinopalatine foramen, when it spreads laterally, initially it enters the pterygomaxillary fossa or pterygopalatine fossa. After entering the pterygopalatine fossa, if its size increases and it extends laterally, it enters the infratemporal fossa through a fissure known as pterygomaxillary fissure. Okay, and posterolaterally, it may enter the infraorbital fissure to enter the orbit. Okay, this is the reason, one of the reasons for orbital extension. Okay, so if this tumor, from the spinopalatine foramen, it grows anteriorly, it involves the posterior wall of the maxillary sinus. Okay, once it erodes, it pushes and erodes the posterior wall of maxillary sinus, it enters the maxillary sinus. When it occupies the maxillary sinus and it erodes the lateral wall of the maxillary sinus, you can find the swelling just below in the region of the cheek, just below the skin. So this is the extension of this tumor anteriorly. This is medially. So if this tumor extends superiorly there is base of skull found by the body of the sphenoid and clivus. So superiorly, if it extends, it enters the sphenoid sinus, and if the sphenoid sinus is full, it erodes the sella turcica and it enters the cavernous sinus. And through the pterygoid process is nothing but a process of the sphenoid bone. Okay, when the pterygoid process is involved, it enters the middle cranial fossa. That is one of the reasons for intracranial extension. Eyes. Once it enters the sphenoid sinus, lateral or posterior walls can be involved. If the lateral wall and anterior wall is involved, it enters the posterior rhythmoidal sinuses. If the posterior wall is involved, it enters directly into the sella turcica, and it may involve the sella turcica, it may involve the cavernous sinus there. So as I told you before, this tumor follows the lines of least resistance, and as this is the most commonest area of origin, it has two components. So there is a foramen. Medial to the foramen is nasal cavity. Lateral to the foramen is pterygopalatine fossa. So the tumor can grow on either side at a time. So that is why sometimes it is known as dumbbell. It looks like a dumbbell. Okay. On either side there is a tumor with a central stalk. Okay. When it fills up the nasal cavity and nasopharynx, it hangs down and it may depress the soft palate. Once it depresses the soft palate, it causes voice changes. Okay. And instead of going posteriorly into the nasopharynx, it can grow anteriorly and occupy the entire nasal cavity, and the polyp may come out through the anterior nares or nostrils. when it occupies the entire nasal cavity on one side, it can push the septum to the opposite side. Okay. The corresponding turbinates and ethmoidal air cells related to antral wall may also suffer pressure atrophy. As I told you before, as the size of the tumor increases, it exerts pressures on surrounding structures causing necrosis. So this pressure atrophy can cause broadening of the nasal bridge. So broadening of the nasal bridge. Unilateral cheek prominence. Okay, unilateral cheek prominence. Displacement of the globe of the eye forwards. It is known as exophthalmos. All these features together, what is known as frog face deformity. Okay, and this is due to involvement of the ethmoidal region. Ethmoidal region involvement causes broadening of the nasal bridge. Maxillary sinus involvement causes cheek prominence. Okay, if the tumor goes into the infraorbital process and enters the orbit, it causes forward displacement of the globe, known as exophthalmos. These three features together known as frog face deformity. Now coming to lateral spread. So from the spinopalatine foramen, this tumor extends laterally into the pterygopalatine fossa. From the pterygopalatine fossa, it can, because the anterior wall of the pterygopalatine fossa is formed by the posterior wall of the maxillary sinus. So whenever this tumor enters the pterygopalatine fossa and increases in size, it invariably exerts pressure on the posterior wall of the maxillary sinus. If this posterior wall of the maxillary sinus erodes, it enters the maxillary sinus and occupies the maxillary sinus. If there is erosion of the lateral wall of the maxillary sinus, it causes cheek swelling. That is the order. Okay. It can, as I told you before, it can enter the orbit through infraorbital fissure causing exophthalmos. It can erode the base of the skull and enter the brain causing intracranial problems. The intracranial problems include increased intracranial pressure causing several problems. The longest intracranial course for a cranial nerve is cranial nerve 4. So whenever there is increase in pressure, this cranial nerve gets involved. So once again, revision. So it extends medially into the posterior nose or nasopharynx, superiorly into the sphenoid orbit. If the sphenoid also is eroded, it can cause intracranial extension. Laterally, it enters the pterygopalatine fossa. From the pterygopalatine fossa through the pterygomaxillary fissure, enters the infratemporal fossa, causing cheek swelling, and it can also cause bowing of the posterior wall of the maxillary sinus. Okay, as I told you before, it can also involve the infratemporal fossa. Anteriorly, it enters the nasal cavity and sinuses. See, this is the MRI scan showing the tumor extending into the maxillary sinus involving the pterygoid plates. As you can see, there are several dots like this. So they gave a name, salt and pepper appearance on the MRI. Okay. Now coming to intracranial extensions. What are the several pathways for intracranial extension? It has been reported that 10 to 20% of the cases show this intracranial extension. and they're always extradural. That is, they are present between the dura and the skull. That is the space they occupy, and they usually be seen in the middle cranial fossa. As you know, the base of the skull contains anterocranial fossa, medial cranial fossa, and posterior cranial fossa. Okay, so it involves the middle cranial fossa. So the first thing is the tumor extension via inferior orbital fissure into the orbit. This is one pathway. Okay, so tumor through the inferior orbital fissure can enter the orbit. From the orbit, after entering the orbit, if there is posterior extension of this tumor via the supraorbital fissure, it enters directly into the middle cranial fossa. So if this is the route of spread into the intracranial space, the tumor is usually located anterolateral to the cavernous sinus, and this is the most common pathway for intracranial spread. So through the inferior orbital fissure, it enters the orbit. From the orbit through the superior orbital fissure, it enters the middle cranial fossa. From the middle cranial fossa, it is present anterolateral to cavernous sinus. Okay. And this is the most common pathway for intracranial spread. The second pathway is expansion of the tumor into the sphenoid sinus with erosion of the lateral wall. If this is the pathway, the tumor is medial to the cavernous sinus. See, this is the body of the sphenoid. These are the vertebrae. This is the soft palate. This is the anterior cranial fossa. Sphenoid. This is the nasopharynx. This forms the roof of the nasopharynx. So, if the tumor spreads in this direction, it involves the sphenoid. Through the lateral wall, it can enter the intracranial cavity. Okay. The third pathway is expansion of the tumor into the pterygoid base and the cancellous diploid of the sphenoid bone, and further superior erosion of greater window of sphenoid with extension to the middle cranial fossa. The third is expansion through the pterygoid base. Now coming to clinical features. These clinical features depend upon the extent of the spread and also site of the spread. Depending upon the site of the spread, the patient will have different symptoms. So, through the sphenopalatine foramen, if the tumor grows medially, involving the nasal cavity, nasopharynx, lacrimal duct, and eustachian tube, then if nasal cavity is involved, patient presents with nasal mass, obstruction, recurrent bleeding. If nasopharynx is involved, patient complains of mouth breathing and rhinolalia clausa. If eustachian tube obstruction, if it causes eustachian tube obstruction, it causes secretory otitis media. Okay. Along with nasal obstruction, if the nasal cavity is involved, it can also cause sinusitis. Okay. So depending upon the site of the spread and extension to different structures, the symptoms differ. Suppose from the sphenopalatine foramen, it enters the pterygopalatine fossa and involves the posterior wall of maxillary sinus. It causes cheek swelling. Okay. From the spina palatine foramen, if it spreads laterally into the pterygopalatine fossa, through the pterygomaxillary fissure into the infratemporal fossa, it can cause this, and through the infraorbital fissure and superior orbital fissure, the symptoms include diplopia, okay, proptosis, because the tumor is entering into the